All right, to continue our discussion on the autonomic nervous system, we will first talk about the sympathetic nervous system. And it's a branch of the autonomic nervous system. And later we will talk about the parasympathetic nervous system, which is the other branch, well, another branch of the autonomic nervous system. And we're not going to talk about the enteric nervous system, which is the third branch of the autonomic nervous system. So first we want to talk about some anatomy. So the sympathetic nervous, well, the autonomic nervous system is a two-neuron system. You have the pre and you have the postganglionic neuron. So what happens is inside, this is the spinal cord. Okay, and you have white matter here, and then you have gray matter here. Right in here, there is what they call the intermediolateral horn of the thoracic spine and the upper lumbar spine. So the sympathetic portion of the autonomic nervous system originates from T1 spinal nerve to L3. Okay, so anywhere from the T1 spinal nerve clear down to the L3, you will find sympathetic fibers leaving the spinal cord. Okay, and so information comes into the spinal cord this way. So this is input or sensory, and it leaves going this way. This is output. So we start here with the preganglionic nucleus right here in the intermediolateral horn. It comes out through these ventral rootlets. Ventral is front side, dorsal is back side. So they come out here, they pass this ganglion root here, the dorsal ganglion root, but the dorsal ganglion root is sensory, which is the input into the nervous system. And once these ventral roots and dorsal roots kind of meet up, they form the spinal nerve. And then after the spinal nerve kind of comes together, there's the dorsal ramus of the spinal nerve and the ventral ramus of the spinal nerve. And so the spinal nerve really, and this could be a tricky question on an exam or whatever, the spinal nerve really is very short distance, okay? But the nerves, the dorsal ramus of the spinal nerve and the ventral ramus of the spinal nerve, both have input, both have information coming in and then going behind on the dorsal root, or they have information going out. So the preganglionic, the first neuron of the sympathetic nervous system, is called the preganglionic nerve or neuron. It starts here. The nucleus starts here in the intermediolateral horn of the spinal column through T1 and L3 areas. It comes out through the ventral roots, passes down by in front of the dorsal root ganglion. They come into the spinal nerve, and then they curve. They curve up into what is called the sympathetic trunk, or the paravertebral sympathetic trunk, or the paravertebral ganglion, this ganglion right here, okay? And then they have they have several options. One is they could come up along they're outside now, and they're traveling, they can travel up the sympathetic trunk, or that's option one. Option two is they could travel down. This is option two. They could synapse right here. So that's the end of it. They could synapse right here. So if we draw a little dot coming out right here, it could synapse. So the dotted line is the postganglionic. So it synapse right here. That's option three, is synapsing right here in the ganglion, in the paravertebral ganglion. And then the postganglionic kind of travels back through what they call these rami communicantes nerves, back into the ventral ramus of the spinal nerve, and go out to, the skin, the musculoskeletal system. And like I said in the last video, the sympathetic nervous system is projected to every part of your body, whereas the parasympathetic nervous system is not. So the sympathetic nervous system has a lot of communications and is in a lot of different places. So number one, so let's review this. It comes out in the intermediolateral horn, comes down through the ventral roots, right through here, and then loops back. It has to loop back first. It loops back through these rami, the first rami, actually it's called white rami communicantes, and I'll show you that in the next video, or in the next picture. The white rami communicantes, and it has options here. Once it hits this sympathetic trunk, it has options. It can either go up the sympathetic trunk, up to the head, or up to the chest, or whatever, or it can go down towards the gut, towards the rectum, down through along the vertebra column. Or it can synapse right here in the ganglion and then come back, and then there's a fourth option I didn't talk about, which means it can come out and it can go to like the gut or something. So there's four options. So it can go up, down, synapse right there, or just continue on. And these are all the preganglionic, the first of the two neuron system of the autonomic nervous system. If it synapses here, then the postganglionic, and again, these are acetylcholine is the neurotransmitter, and they synapse on nicotinic receptors on the receiving side of the postganglionic nerve, and they go out through these. Then it goes out through a gray rami communicante and goes out through the ventral ramus of the spinal nerve. So another picture here is right here, the intermediolateral part of the spinal cord. These are where the cell body start, okay? And this is the efferent, or the one that's exiting. Information travels in this direction out of it. And this dorsal root ganglion on the receiving side, this is input or sensory, and this is output. This dorsal root ganglion, what it is the cell bodies of these sensory nerves. So these sensory nerves, or neurons, they can be, as long as clear down to your foot, your big toe, clear up into your cord. So these neurons can be very, 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 very long. And where these neuron cell bodies reside is in these dorsal root ganglions at each spinal nerve. So the input comes in this way, and there's interneurons, and on the dorsal horn they can synapse. The information go back up to higher levels in the central nervous system. They can go up or down or whatever. Or they could just kind of synapse right here if you have reflexes. When the doctor does your reflexes, they kind of just synapse right back onto the evariant, and that's how you can get test your reflexes. But anyways, I just wanted to show you this picture to kind of get a different view of information coming in and information coming out of the spinal cord. So finally, the last picture to kind of understand the anatomy and where everything is going is information goes into the spinal cord through these dorsal root ganglions, and they arrive at the spinal cord on the dorsal horn up here, and then they kind of come around, and then this is the ventral nerve root. Okay, so the ventral nerve root comes out, and so this dotted line represents a preganglionic sympathetic neuron. So it comes out, and like I said, it has to communicate first with this prevertebral sympathetic ganglion, or the sympathetic trunk. And so it comes through the white ramus, and then like I said before, it can either synapse here, that's one option. It can synapse right in this ganglion, so then the postganglionic cell bodies make up these paravertebral sympathetic ganglions in the sympathetic trunk, and then they go out through the gray rami into the spinal nerve and out the ventral root, or the posterior or the dorsal root of the spinal nerve. Or another option is that they can go straight through down into some splanchnic nerves, and we'll talk about that in a second. Or they can go down the sympathetic trunk, or they can go up the sympathetic trunk. So if this was an example of a T1 spinal nerve, well, we have to have sympathetic innervation to our face and to our neck, and because the sympathetic nervous system starts in T1, it has to go up in thoracic vertebra number 1, which is, more along the top of our rib cage here. It has to go up to our face, and so a lot of these T1 is going to be there. A lot of them are going to choose to go up. Several fibers are going to choose to go up the sympathetic chain so they can synapse and start the second, or the postganglionic neuron. So we talked about this in the last video, but I want to kind of review it. This stuff can be confusing, so review and repetition brings conviction. So I want to go over this again. So here, this is T1 through L3, and this is where the sympathetic division of the autonomic nervous system, the preganglionic neurons, give rise to or originate from. So like I said, the T1s, a lot of them are going to choose to come out of the spinal cord and actually travel up to 3 ganglion. And the ganglion is where all the cell bodies of the postganglionic cell reside. And so there's the superior cervical ganglion, the middle cervical ganglion, and the inferior cervical ganglion. So the superior cervical ganglion gives rise to the radial muscle of the iris, responsible for dilatation of the pupil. It also innervates the Mueller muscle, which assists in elevating the eyelid, and it innervates the salivary glands and the sweat glands on the face. So that is all the superior cervical ganglion, this one right here. And so these postganglionic neurons, they come in and they innervate the eye, lacrimal gland, submandibular gland, sublingual glands, and parotid gland. And like I said in the last video, this is acetylcholine, the neurotransmitter, and the receptor is nicotinic. And at all of these junctions here, this is an adrenergic receptor, and norepinephrine, epinephrine are the main 2 neurotransmitters in these areas. So now after we get back through T1 to T3, a lot of them are going to go superior or up the chain, but through here, T4 to T12ish, a lot of them are going to choose to just go straight through, and all of these preganglionic neurons make up what they call the greater splanchnic nerve. And once that comes in, it gives rise to the celiac ganglion, and they synapse with a bunch of them, with a bunch of postganglionic sympathetic nerves, and they give rise to, or they innervate the liver, the gallbladder, the stomach, small intestine, kidneys. And you can see, we talked about this in the last video, so I don't want to belabor it too much. But, oh yeah, the middle cervical ganglion and the inferior cervical ganglion, they innervate organs of the chest, including the trachea, esophagus, heart, and lungs. The sympathetic division can produce local or widespread responses. So the sympathetic tone, what does that mean? Well, the sympathetic division exerts a continuous influence on the organs it innervates, okay? And this is produced by a persistent or a continuous discharge of those neurotransmitters through the sympathetic nerves or neurons on the affected organs. So I made a little cartoon here. So this is kind of a persistent. This happens all the time under normal physiological circumstances. This neuron, this preganglionic nerve, is stimulating the postganglionic nerve, and the postganglionic nerve is constantly stimulating the organ or cells that it's responsible for. Okay? So for an example, if I increase the rate to the iris of this, if I tell this cell body, boom, 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 if I stimulate this cell body faster, what is going to happen is there's going to be faster action potentials. Okay? And if I increase the rate to the iris, well, then that's going to cause dilatation of the pupil. So your pupils are going to become enlarged. In the case of fight or flight, I want to get as much information through my eye as possible, so I'm going to have a dilatation of the pupil so I can see exactly what's going on, and I can obtain a lot of information through the eye. And so you increase your rate to the iris, then that's going to cause dilatation of the pupil. Or if I decrease the rate to the iris, what that's going to do is that's going to cause pupillary constriction, because the pupil is not going to receive as much neurotransmitter, and so that's going to cause the pupil to constrict down. So that's kind of the concept of sympathetic tone. Next concept is called divergence. And so this is an important concept too, is that the number of postganglionic axons emerging from the paravertebral ganglion is greater than the number of preganglionic neurons that originate in the spinal cord. So in the spinal cord, we have a certain amount of preganglionic nerves. What's this saying is that one of these preganglionics innervate, 5, 6, 7. It's estimated that there is a 100-to-1 ratio. So this preganglionic nerve could innervate, it's an estimate, as up to 100 postganglionic nerves. Okay? And the reason why is because this divergent enables the sympathetic nervous system to produce widespread responses of many effectors when physiological necessary, when it's required. Or another preganglionic could come in here and just synapse with 2 of these. And so then that would give more of a specific response rather than a widespread response. So divergence and sympathetic tone are 2 concepts that are important to the sympathetic nervous system. So another concept of the central nervous system, or the sympathetic nervous system, is the concept of the stimulation of the adrenal medulla mimics sympathetic function. So at the end of the postganglionic sympathetic nervous system, we have norepinephrine and epinephrine acting on adrenergic receptors. So you've already seen this picture, but this is a preganglionic coming out, a preganglionic sympathetic neuron coming out of ventral roots, crossing the white rami into the paravertebral sympathetic ganglion, or the sympathetic trunk that runs up and down adjacent to this vertebral bodies, or the vertebral column, the spinal column, or the spine. So that white ramus, or that preganglionic sympathetic neuron, passes right through that ganglion, travels out, okay, and in this case, in the case of the adrenal medulla, it passes right through the celiac ganglion. It doesn't synapse, and this is still the preganglionic cell. Okay, comes out, and then it finds its way to the adrenal glands, which sit on top of each kidney, and it innervates the adrenal gland. Okay, so in addition to the divergence and sympathetic division of the autonomic nervous system, there is a hormonal part, or a hormonal mechanism of the sympathetic nervous system. And what it does is those hormones are released from the adrenal gland, and they act on both alpha and beta adrenergic receptors. So any cell or organ that has alpha or beta adrenergic receptors, these hormones that are released from the adrenal glands also act on these receptors, along with those that are innervated with sympathetic nerves. And the hormone is the catecholamines, epinephrine, which is secreted along with lesser amounts of the norepinephrine. So from the adrenal gland, the epinephrine is secreted 8 times more than the norepinephrine. So epinephrine is the catecholamine that is most secreted from the adrenal glands. And so that is in response to the adrenal medulla during generalized response. And cells of the adrenal medulla are innervated by the lesser splanchnic nerve. So this is the lesser splanchnic nerve. Okay, so now let's zoom in on the adrenal glands. So this is the adrenal cortex, is the outer side where steroids are produced, and some steroids, and the inside is called the adrenal medulla. And inside the adrenal medulla, you have chromaffin cells. Okay, and so the chromaffin cells, what they do is they get innervated by the preganglionic sympathetic axons. Okay, and this is the preganglionic. So in this case, there is no postganglionic. There's just preganglionic sympathetic axons. They innervate these chromaffin cells. These chromaffin cells produce epinephrine more than norepinephrine in a ratio to 8:1. And so these epinephrine and norepinephrine are stored in these vesicles. So when they become stimulated, they dump these epinephrine and norepinephrine into the blood supply, and the vein takes out the epinephrine and norepinephrine. So this is kind of a neuroendocrine gland, if you will, kind of like the pituitary. And so they dump out this norepinephrine and epinephrine into this vein here, and then now you got hormones in the blood, and any place where there's an alpha or beta adrenergic receptor, this is going to stimulate it. And so this is kind of a second punch, if you will, to the stimulation of the sympathetic nervous system. So the classic presentation or example of the sympathetic response is fight or flight. You know, if some guy is being chased by a lion, you know, he's going to have physiological changes, and that is going to, you know, enable him to hopefully run away from the lion. Because most of us don't run away from lions, I used the example of police cars in the last videos, and so I'll continue this police car analogy. If you are driving down the road and you see a crash, or you're involved in a crash, or if you're speeding and then a cop flips on his lights and starts to chase you to give you a ticket, you feel the fight or flight response, most likely. And so what happens is that there are some components of the response that result from the direct effects of the sympathetic neuron activation, although the action of epinephrine is also secreted by the adrenal medulla. So the sympathetic nervous system and the epinephrine or the norepinephrine secreted from the adrenal medulla also play a role in this fight or flight response. Okay? And so sympathetic stimulation of the heart and blood vessels, that causes a rise in the blood pressure because of increased cardiac output and increased total peripheral resistance. So the total peripheral resistance means that some of the blood vessels are going to be constricted to give more blood to cardiac output, and you see a rise in blood pressure. There's going to be redistribution of the blood flow. So all these are components of the fight or flight response. Severe activation of the sympathetic nervous system. So you're going to see redistribution of blood flows, the muscles and heart receive more blood, the splanchnic territory and the skin receive less, so inhibition or lack of nerve stimulation or a decrease in sympathetic tone to the splenic territory, and the skin, mostly the skin, the splenic territory, receive activation of the parasympathetic, which is counteracts the sympathetic activity, but less sympathetic tone, mostly to the skin. So you're going to have the redistribution of the blood. The blood gases exchanges are going to increase because you're going to underdo a lot of cellular respiration, so you're going to need more oxygen to the tissues. And so you see an acceleration in the respiratory rate, and you see dilatation of the bronchial tree. Your salivary secretion is going to be reduced. You're not going to be needing your amylase and the other salivary enzymes to prepare you for a nice tasty meal during the fight or flight. You're going to have increased metabolic substrates. So glucose, fatty acids, they're going to be needed by the muscles and the other parts that are undergoing increased cellular respiration. And so this is the metabolic substrates that are needed is met by the actions of the sympathetic nerves and circulating epinephrine on hepatocytes and adipose tissues. So glycogenolysis mobilizes stored glycogen from the liver and increases the plasma levels of glucose. Adipose tissues, they're going to undergo lipolysis and converts stored triglycerides into free fatty acids that can be used for energy. So what's the result is you have increased heat production from contracting muscles. So your body temperature is going to rise because all that cellular respiration is exothermic, and you're going to have an increased heat production. And so what happens is the sympathetic innervation of the skin can adjust blood flow from the skin, and that can cause heat exchange by vasodilation. So if you're getting hot, your skin is going to cause vasodilation, and that is going to dissipate heat, or it can undergo vasoconstriction to protect the blood volume. So your autonomic nervous system automatically balances that, which I am grateful for that I don't have to keep control about that. So sweat gland stimulations too, what happens is they secrete a watery fluid, also known as sweat, and then that evaporation then dissipates body heat. So through the evaporation of sweat, our body dissipates heat. And so the constriction of the skin vasculature concurrent with sweat gland activation produces the cold, clammy skin typical of a frightened person. So people that undergo shock, their skin is cold and clammy, and that's because they are undergoing a massive sympathetic system excitatory response. Last but not least, we have to correlate this to the human body and to medicine. So Horner syndrome. Let's talk about Horner's syndrome. Classic signs and symptoms of Horner syndrome is meiosis, ptosis, and anhidrosis. That's a nice little rhyme there. So what meiosis is a partial constriction of the pupil as a result of loss of the sympathetic pupil dilator action. So hopefully that makes a little sense to you in what we've just talked about. So you see a constriction of the pupil here in this infant. In this child, you see constriction in this pupil, and that's because somehow the sympathetic nerve has a lesion in it. You see a drooping eyelid, so this eyelid's drooping down, this eyelid's drooping down, and that's called ptosis, and that is a result of the loss of sympathetic innervation to the Mueller muscle of the eyelid. And you get anhidrosis. So what happens is you see a dryness of the face. A dryness of the face as a result of the lack of sympathetic activation to the facial sweat gland. So they complain of, my face is really dry, my eyelids drooping, and when you look at them, you're like, holy smokes, the one pupil is a lot smaller than the other. That's Horner syndrome, indicative of sympathetic pathway lesions. And so what happens is, what are the etiologies of Horner syndrome? They include brainstem lesions such as produced by strokes, which interrupt the tracts that descend to the sympathetic neurons in the spinal cord. So if you have a stroke, you could knock out these nervous system neurons. Now these are not preganglionic, remember. These are just interneurons inside the central nervous system. This is the preganglionic. These are the preganglionic right here. And because the preganglionic cell bodies are in the intermediolateral horn of the spinal cord. These are not preganglionic, these are. And so inside the nervous system, you have these neurons coming down that synapse or connect to this preganglionic neuron. And so these can be taken out by strokes, and that can cause Horner syndrome. Or you can have an upper thoracic nerve root lesion, such as those produced by extensive traction. If you yank on a kid's arm, or if a kid gets, or somebody's arm gets severely tractioned, you can have upper thoracic nerve root lesions. Or you can have cancer in the lungs that spread to the nerve roots. That can also cause Horner syndrome. You can have cervical paravertebral ganglion lesions, so the superior cervical ganglion gets knocked out, or the medial or the inferior cervical ganglion, they can get knocked out as well, and that can be from accidental or surgical trauma or metastatic cancer. Cancer can spread to these, and they can get knocked out, which causes Horner syndrome. Or you can have an arterial injury to the neck. So if you're in maybe in a whiplash, a car accident, or sports or something, and you get an extreme hyperextension, which means that your head is whipped back far, 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 you have, or direct trauma, that can cause postganglionic axons traveling in the carotid periarterial plexus. So right here, you have these postganglionic, see, because this is the synapse here, from the pre to the postganglionic neuron, they travel along this carotid plexus. And so if this carotid artery gets dissected or gets ripped in half or torn, then that can cause problems in these postganglionic nerves that innervate this dilator pupae muscle, and so that can cause the constriction in the pupil. And so these are kind of the etiologies or causes of Horner syndrome. We'll see you in the next video.